Hello everyone! This unit we are going to talk about psychological disorders and therapies. I know there's a lot of reading sections to cover, and so I'm going to try to keep these PowerPoints as compact as possible. And we're first going to start off with anxiety and related disorders. So we're going to move through the different disorders, and then we're going to address the therapeutic approaches. And there will be intermittent talk of different therapeutic approaches for the specified disorder. So, for example, we're going to talk about anxiety and related disorders, and at the end, we're going to summarize that with more information on therapies specific to anxiety disorders. With that being said, our learning objectives are just to understand the differences between anxiety and anxiety disorders, because a lot of people experience anxiety. So what constitutes an anxiety disorder? We're also going to look at vulnerabilities, main diagnostic features of different anxiety disorders, and be able to differentiate between disordered and non-disordered functioning. So, my little warning before we get started with any of these sections is that some of the disorders we are going to study may sound like they apply to you, right? This has a lot to do with our experiences and knowing ourselves, and also confirmation bias. We may think, oh, look, I have that, or oh, look, I do that. Now, this is not saying you don't have the disorder, but sometimes we try to diagnose ourselves in this section. Try not to do that, because there are people who have been professionally trained to do so, and using very specific criteria from the Diagnostic and Statistical Manual of Psychological Disorders. And so with that being said, there's going to be different criteria. So maybe you've had this happen, an experience one time. That won't constitute a disorder. There's also a lot of different criteria. So make sure you're not diagnosing yourself. But if you should feel that these disorders affect you, or this sounds like you and you're really convinced of it, I would recommend you contact Beaufort County Community College Counseling Services. I put the link hyperlinked here. It has the different numbers for the counselors and the services they provide, because they will be able to address any inquiries you have. And they're on campus, and they're already a resource you're paying for, so you might as well use them. So let's get started. Now, an introduction to anxiety. Anxiety, first of all, is not always bad. It has a negative connotation, but it's a good thing within reason. It motivates us to do different things, right? If you have a due date coming up, you may feel anxious about it, but that anxiety is pushing us toward completion. But when we're talking about anxieties with psychological disorders, we're looking at a negative mood state that is accompanied by bodily symptoms such as increased heart rate, muscle tension, a sense of unease, and apprehension about the future. So it's like an excessive worry. And so the point where anxiety becomes disordered is when it interferes with a person's life. And you'll see what I mean by that as we go through the different disorders. But it's going to impact daily tasks of living. Maybe someone with social anxiety disorder decides not to leave their house because they don't want to encounter different social situations. That would be an impact on their daily tasks, right? And so disorders as a whole, including anxiety disorders, we're also going to talk about mood disorders and the like, follow kind of this. We have two different models for how they kind of manifest themselves. So we have the biopsychosocial model. This is looking at interdependent factors, not independent, interdependent. They rely on one another. So you'll see in this picture I have, mental health is in the middle. And it's going to be an amalgamation of our social and environment. So our socialization, our environment, so our culture, our peer group, our school, all these different things that come to play that are going to affect us. Our psychological state, so our perceptions, how we have coping skills. People are going to differ in how they cope with trauma, for example. Not everyone who experienced trauma will have PTSD. So there are going to be individual psychological difference that kind of contribute to whether someone gets a disorder or not, or develops a disorder or not. We're also going to look at biological factors. So this is just going to look at your neurochemistry. Maybe some of your neurotransmitters are off, right? We talk about depression and serotonin. All of those different neurotransmitters we talked about in the biology, kind of psychobiology section are going to come into play here. So bio, psycho, social model, and interdependent factors that contribute to one's mental health. Now, with that being said, there's another thing, this is not mentioned in your text, but it's important, the diathesis stress model. That just looks at someone's predisposition to have a psychological disorder. So sometimes, for example, if someone has a substance abuse disorder, let's say their father is an alcoholic, that person is more likely to develop alcoholism themselves. There's a predisposition there. And it depends on what kind of stressor can kind of activate that propensity. So that's what we're looking at with mental health. You know, what is someone's predisposition? What factors cause someone to be predisposed to have a different anxiety disorder, for example? And what stressor can activate it? Because sometimes it could be a trauma, like a combat veteran with PTSD. So that's what we're going to talk about today. And just know that as we go through these different topics, they will be covered thoroughly if you take abnormal psychology, Psych 281. But for our intents and purposes, we are going to keep them pretty succinct. So generalized anxiety disorder, or GAD, is characterized by excessive worry about everyday things that is at a level that is out of proportion to the specific causes of worry. Now, this is not just, it's like excessive worry, but not everyone fits this criteria. As you can see, you know, about 5.7% of the US population at one point in their life can fit this criteria of this disorder, because some of the DSM criteria are very general. But it is more than excessive worry. It's worry about everything from minor events to catastrophic things. So maybe they're worried about where they're going to choose to eat, you know, choose what to eat for dinner. But they may also worry about their credit card debt or their student loans or something. So this worrying affects multiple facets of their life, and it's impossible to turn off. It's worrying about nearly everything. And there's also going to be, with these anxiety disorders, a physiological component. Because with anxiety, we have that mind-body dualism and how our mind affects our physical state, as we talked about in the psychobiology chapter. Well, physiologically, we're going to have muscle tension or fatigue as a result sometimes of fight or flight responses activated in response to anxiety. There's going to be different physical cues that we read as a part of experiencing anxiety. People with GAD also experience agitation or restlessness, so part of that excessive worry comes a sense of irritability. And the idea behind this is, with the worry, they're trying to establish control in their life over things that they may not necessarily have control over. It's kind of a way to gain that back or feel like they are. So often they feel that worrying about it is going to help them, if that makes sense. And with sleep difficulties are going to be prevalent with this. And I know you may be reading through this and you're like, well, I fit some of those, right? Because the criteria is quite broad, but this has to occur for about at least 6 months, and it has to be ongoing and take up a majority of one's day. And that will be diagnosed, you know, by visiting a clinical psychologist or a counselor. They will be able to discern whether one meets the criteria for generalized anxiety disorder, but it's very common in terms of anxiety disorders. Then we have panic disorder. Panic disorder is characterized by frequent panic attacks. So, I think I read in a statistic somewhere, everyone in their lifetime will experience a panic attack. It's how you react to it that determines if you will have subsequent panic attacks. So this can be something like restricted airways, restricted breathing, rapid heart rate. It's our fight or flight response activating, and we don't really know where it's activating or why it's activating. We just kind of feel that sympathetic nervous system acting up, and so we misinterpret those physiological cues, right? And that lends itself to this vicious cycle of anxiety. So maybe if I am out in a dimly lit room, I don't usually go in dimly lit rooms, but all of a sudden I experience a panic attack. I may misinterpret that physiological clue as it being related to somewhere in that area I am. Maybe I've attributed it to that certain lighting because it's something new I experienced. And so then I may develop an anxiety or an association with those panic attacks and dimly lit rooms, and I may avoid dimly lit rooms. So it becomes this vicious cycle in trying to avoid different things that we've associated with those panic attacks. But also, for this disorder to be diagnosed, you also have to have continued anxiety and avoidance related to the attack for at least 1 month. So, like I said, if I had a panic attack because I went to a really crowded auditorium, maybe I think that, I'm a little claustrophobic or something. No, I don't want to say that because that's a specific phobia. Just rewind and forget I said that. But maybe I will attribute it to wherever I am. So the dimly lit room, I may avoid dimly lit rooms, or I may keep all the lights on at one time. And it causes significant distress and interference in someone's life because they're going to change their life to accommodate this new avoidance. So if I'm going to avoid turning the lights off, maybe I keep the lights on 24/7. And maybe that affects other different things in how I function. Because anxiety has this way of snowballing, right? We have one set of specific criteria that we're like, okay, I'm going to avoid bees because I had a panic attack when I saw a bee. Well, then you notice bees tend to hang out in garbage cans. So you go, well, I'm going to stay away from the garbage can. But then the garbage can is down an alleyway. So maybe I'm going to avoid alleyways because they have garbage cans which have bees, which gave me a panic attack. See how it seems very irrational, but when someone's in that state of anxiety, it makes sense. But panic disorder is going to be prevalent. Around 4% of the US population is going to meet this criteria at one point or another in their life. And how does this relate to agoraphobia? Well, sometimes agoraphobia develops when someone relates that panic attack to a different place that's open or crowded. So they're going to avoid those situations where they're in an area that is open or crowded. Now, if they have agoraphobia without the panic attacks, that's a different diagnosis. That's a specific phobia, so it'll be treated a little differently. But sometimes agoraphobia can result from panic disorder. Now, specific phobias are going to be what you hear about when people say arachnophobia, the fear of spiders, chlorophobia, the fear of clowns, right? So I found this pretty comprehensive list of different fears or phobias, but that's not all of them. So just a note. But specific phobias are going to be an irrational fear of a specific object or situation that substantially interferes with a person's ability to function. Now, you can have a fear of something, but a phobia is when it's going to interfere with your ability to function. For example, if you have a horrific fear of using a pencil, I don't know, I'm making something up right now. So you are using a pencil or a pen. You are not going to use a pencil or pen to handwrite anything. How could that affect your life? You may not be able to take notes adequately, or you have to use a computer device for everything. Maybe you can't take tests like everyone else, right? That's what we're talking about impacting your daily life, when you change your routine to accommodate this fear. Now, I put in this picture because it's maybe a little before your time, but on the Maury Show, they used to put people with different fears that they found odd on the show. And there was one woman who was scared of cotton balls. And so they had this man come out dressed in cotton balls, and they pretty much torture her for a second. And they tried to use different methods to get these people to get over their fears. And they worked for short term and sensationalizing the show. But anyway, I just put that there because people do develop fears that you wouldn't think of. And they try to avoid those things. But phobias, since the list is so long, they can be divided into general categories. So blood injury injection types, situational types. So this could be like claustrophobia, where you're in a specific situation. If you don't know, claustrophobia is the fear of enclosed or tight spaces. Natural environment type, so maybe you have a fear of tornadoes and you live in Kansas. That seems not too irrational. Animal types, so any phobias related to fear of dogs, fear of cats, etc. And then others, so phobias that don't specifically kind of fall in those previous 4 categories, like the fear of vomiting. That is a phobia, but it doesn't really follow those different categories. Social anxiety disorder is going to be social phobia, also known as social phobia. So it's a condition marked by an acute fear of social situations, which leads to worry and diminished day-to-day functioning. So a lot of times this social anxiety stems from the fear of negative evaluation from peers. Now it could have a lot of these and disorders can result from childhood experiences or early trauma. Maybe they were negatively evaluated by a parent or a caretaker figure. Maybe they were verbally abused in a sense. So that evaluation is kind of carried on, and it forms this vicious cycle where they're scared of going out and being evaluated, so they stay inside. And then when they stay inside, you become more isolated socially. So it leads to diminished social skills and the want to stay inside. So you see how that's very cyclical? Well, typically, this person's going to avoid social situations, so they're also going to, if they do go into those social situations, they're going to be very distressed about it. So this could be a one-on-one conversation, or it could be an assertive kind of stance, like asking someone to do something. That could be very distressing. Maybe ordering their own food at a restaurant. They can't do those types of things. And that's going to interfere with your daily life. And social anxiety disorder will also impact your occupational and or academic functioning. So maybe someone with social anxiety disorder, maybe they have a fear of public speaking. So that presentation component. And they're required as a part of the academic team to do a speech. Well, maybe they don't join that academic speech for fear of or academic debate team or whatever, because they can't do that 1-minute speech at the end of the semester. So that's an example of how those different that social anxiety disorder could affect their life. And this one's pretty prevalent, with about 12.1% of the population in the US meeting this criteria. And here's just kind of an informational poster about social anxiety to just kind of understand that it's more than shyness. There's different criteria. This is from the National Institute of Mental Health, so a very reputable source. Yeah. Social anxiety disorder. Now, we're also going to talk about post-traumatic stress disorder, PTSD. And this prevalence is typically low. About 6.8% of the population meets this criteria in the US, because it has to stem from a traumatic event or experience. Now, if we look at the definition, it says a sense of intense fear triggered by memories of a past traumatic event that another traumatic event might occur. So we think that it's going to happen again. And this may include feelings of isolation and emotional numbing. So not being able to feel, and kind of just isolation, meaning taking ourselves away from others. It's important to note that not everyone who experiences trauma is going to develop a disorder. This goes back to that biopsychosocial model, as I mentioned. There's going to be different social, psychological, and biological factors that lend themselves to how someone develops a disorder. Typically, what we see with this disorder is that people experience a traumatic event, that maybe there was impending or possible death or sexual violence. That's usually the criteria we use for a traumatic event or experience. And this can be experienced firsthand, or maybe watching someone else as a witness, or confronting these things every day, like our text talks about medical professionals like EMTs. Well, when someone experiences these events and they develop PTSD, they're going to have intrusive reminders of events. So there's going to be memories that come back into their head and kind of attack their brain, and they can't control those thoughts. And so these can be nightmares or intrusive memories, because when you sleep, you can't really control your nightmares or what occurs. So maybe those nightmares are related to that event. There's also an intense fear that the event might occur again, as we mentioned, and sometimes they may have moments where they feel like they are reliving the event or having what is called a flashback. Now, as an example, I had a friend who was a combat veteran, a Marine I think he served in Iraq, and he had post-traumatic stress disorder. Now, he could play first-person shooter games like Call of Duty, but on the 4th of July, the fireworks would be a reminder of the trigger of the combat that he was in. Now, that has to do with classical conditioning, as we talked about. We learn to associate different experiences, different sensory experiences with that event. Maybe someone was in combat and, like our text said, they smelled gas before there was an explosion on their vehicle, right? That smell of that different substance could be a trigger for that person upon their return home. And this is also true so I've included a link for PTSD for veterans. If that's relevant to you or someone you know, check out that link. Also PTSD is possible among sexual assault survivors. So if someone is raped, there are different associations that are made that could be made there, such as, maybe a certain smell a person had, or, the type of clothes they were wearing, or maybe even the act of engaging in sexual intercourse with a consensual partner. There could still be triggers there that the person has to move past, like with therapy or other different things like that. And then we have obsessive compulsive disorder. Along with a lot of these disorders, I feel like this is misrepresented, or we tend to use these in common lexicon, like very flippantly. Like, oh yeah, I have OCD, I like my TV channel on volume 25 and not 24, right? People kind of use those like, oh, I have PTSD from this, which, we shouldn't do because it minimizes someone else's experience with that disorder. But we'll get there. But OCD is not what we normally think. It's not wanting everything straight and orderly and neat for the sake of neatness and being anal retentive, if we're going to call in Freud. It's a disorder characterized by the desire to engage in certain behaviors excessively or compulsively in the hopes of reducing anxiety. So you have obsessions. Those are the obsessive thoughts or the intrusive thoughts. And then you have the compulsions, which are the behaviors one engages in to kind of make those obsessive thoughts go away. So this is where we get this idea of cleaning with obsessive compulsive disorder. Someone with OCD touches a doorknob, but they have this obsession that there are germs on the doorknob. It is going to make them sick. So they have to wash their hands every time they touch the doorknob so that they don't get sick and they don't die. That is kind of how the thought process works. So they have to wash their hands every time they touch a doorknob. That's the compulsion. That minimizes the obsession, the thought, the behavior that decreases the anxiety. And so if they're not able to engage in that compulsive behavior, it is going to cause great distress in the individual. And a lot of times, sometimes these things can not have any kind of logic to them. Sometimes people be like, oh, well, this has to be straight or else my dog is going... I know some of you may be like, what? But that's how it works. Again, with that anxiety, it's going to snowball and make these associations that don't make sense logically. And the thing with anxiety is that people often who have anxiety understand the irrationality. But then there's always a part of the brain that goes, well, but you washed your hands every time you touched the doorknob and you haven't gotten sick yet. So it reinforces those behaviors because of the relief one feels when they do it. And this is going to have a significant impairment in their functioning. This person may decide to wear gloves all the time, if we're going to talk about the person who's obsessed with germs and can't touch doorknobs. Well, they may also think, well, I can't touch handrails. I can't touch the table. I can't touch keyboards. It's going to grow and snowball. How will that keep growing to things they can't touch because of germs? And that's going to cause impairment in their daily functioning. And in order for this to be diagnosed, clinically diagnosed, significant time has to be engaged in those compulsions, at least an hour a day, which is just strictly doing different behaviors. The prevalence is pretty low in comparison to the other anxiety disorders we talked about 1.6 of the population. 1.6% will at one point meet the criteria for this disorder. So when someone says, yes, I have OCD about this, they might have OCD, but usually we use that very flippantly. So, OCD has to have the obsessive thought with the compulsion, not just, oh, I have to clean for cleaning's sake because I like being clean, right? It's not about liking it, it's about reducing anxiety because of it. Another example could be religious rituals. Different religions, when they talk about, different sins or acts against God, I'm speaking strictly of the Abrahamic faiths, Judaism, Islam, and Christianity. There are different components that go into that, praying and talking about reflection and trying to get forgiveness for different sins. These are common components. Well, sometimes people can engage obsessively in religious rituals for fear of some kind of omnipotent retribution. That could be another example of obsessive compulsive disorder. So it's not just cleaning, not just organizing. And I think that's the main thing I wanted you to get from this slide. And then lastly, treatments and conclusion. Medications can often be utilized for anti-anxiety and antidepressants for anxiety and depression. Sometimes depression tends to be comorbid with anxiety, meaning they occur together. But that's why we use antidepressants, but sometimes with anti-anxiety. Sometimes, though, anti-anxiety meds can be highly habit-forming or addictive. And if you use anti-anxiety meds alone, there tends to be a relapse after medications. So that relapse level is high after medications, meaning that people tend to kind of fall back into their same anxiety patterns if they don't have the meds anymore. So one of the more effective things is kind of using cognitive behavioral therapies in conjunction with medications sometimes. But cognitive behavioral therapy is like looking at the foundation, trying to change your cognitive patterns. We talked about how people think and think about their world. Well, those cognitive patterns in cognitive behavioral therapy, we're trying to look at how that person thinks about their experience with their anxiety and changing their behavior accordingly. We're trying to change how they think about situations so that instead of thinking, oh, I'm going to die if I touch this doorknob because the germs are going to attack me, maybe we want them to think, the doorknob isn't that dirty. I don't have to wash my hands every time I touch the doorknob, maybe just before I eat. So that's changing a cognition and a behavioral pattern. For example, exposure response prevention, that's going to look at, that's specifically for obsessive compulsive disorder. So if we wanted to expose someone to one of their obsessions or fears, we may have them touch a doorknob, and response prevention not allow them to wash their hands because we're trying to get them to stop engaging that behavior and reinforcing that behavior cycle. Stay tuned for the next section. I know this one was a little longer. I'll try to keep them shorter, at least under 30.